the next 20 minutes, I'm going to kind of race through advances in melanoma prevention, screening, detection. I did have give Sam a PDF copy of the slides, so don't feel like you have to take a lot of notes, and I am a fairly rapid speaker, but I will try to get through this. So this year we're going to see over 91,000 Americans who develop invasive melanoma, which means it could have the potential to metastasize, although fortunately most don't if we detect them early. At least 87,000 cases of melanoma in situ, so that's confined to the top layer of the skin, tends to be cured with surgery or other treatment modalities. Right now melanoma is the 5th most common cancer in men and the 6th in women. And we've seen some declines in incidence in younger age people, but we're still seeing a spike of melanoma in women over the age of 44. And this is really related to this birth cohort effect, women born after 1965, with environmental exposure being the advent of tanning beds in the 80s, which is a real disappointment. The NCCN risk factors for melanoma, I wrote this page a few years ago for both primary and multiple melanomas, but if you take a look at the top, we have older age and male sex, which are predominant risk factors, and then a phenotypic predisposition, which really is your mole pattern, whether you have atypical moles, large numbers of moles, and then your skin type. Light-skinned patients are the ones who tend to get melanoma because of that susceptibility to harmful UV irradiation. When we take a look at melanoma skin cancer control, we talk about both primary and secondary prevention. So primary prevention is designed to stop the disease before it develops. And the main way we do this with melanoma is to reduce harmful sun exposure behaviors, so that behavioral prevention. We also have chemoprevention, which is a sort of a fledgling field, and I'll talk about that, where we could use safe and effective drugs, vitamin supplements to actually prevent the disease. And then secondary prevention is really those early detection efforts where we focus on the patient, teaching them how to do a self-skin exam, how to look at their skin, know what melanoma looks like. We teach providers, particularly primary care providers, how to do the same. And that should come together in a medical visit where we detect earlier, more curable melanoma. Now, about 3 years ago, the CDC put out a report saying that if we were to enact a comprehensive national skin cancer prevention program, we could prevent about 230,000 cases of melanoma and almost $3 billion in initial first-year treatment costs between the years of 2020 and 2030, when we anticipate we're still going to be seeing this marked increase in melanoma incidence, the number of new cases. We know that melanoma can be prevented by reducing harmful ultraviolet radiation exposure from indoor tanning and sunbathing, and we also know that we can affect this change by aggressive sun protection. About 65% of melanomas in whites and 90% of the non-melanoma skin cancers we see, basal cells and squamous cells, are attributable to sun exposure. We know sun exposure starts early in life if you think about how much more sun kids are getting before they have jobs and are working and so on in their 20s. So we know a lot of the sun exposure, though it's cumulative, occurs in early life. Now for the first time we have a randomized controlled trial suggesting that sunscreen itself could really significantly reduce melanoma risk. And this is kind of what we've seen with melanoma incidence in the last half of the 20th century. It far outpaced all other cancers by about 300%, in part due to better detection and screening and picking up low biologically indolent, less harmful tumors. But in turn, we and others have shown that the absolute rates of thick tumors, the thickest tumors that tend to metastasize, spread to other parts of the body, are really still climbing without abatement. There was a great study that was done out of NYU, my colleagues David Polsky and so on, and they took a look at leisure time activities, advertising, and basically clothing, what was in magazines and so on from the last century. And what they did is correlate this over different time periods in both men and women. And here we have Sean Connery at the end, and thankfully no bathing suits that look like Bharat on this one. But what was really remarkable is that these changes that we saw with increased exposure of skin, more sun-exposed skin, over the entire 20th century, really correlating with that marked increase in melanoma incidence. Tanning beds are bad news. They emit stronger UVA and UVB than natural sunlight, and we know that a single issue or single time of a patient using a tanning bed increases their melanoma risk by about 1.8%, and usually, as we all know, tanning beds are marketed to young women. We see an increase in tanning bed use in gay men now, but most people use them multiple times. It's not a one-time event. And it's estimated really that more people develop skin cancer, including all skin cancers, from indoor tanning than they do from lung cancer from smoking. Aim at Melanoma through the work of Sam and Valerie Guild and other organizations has really helped to spearhead the legislation to prohibit tanning bed use by minors. We are still not where we need to be. Right now we have 17 states and the District of Columbia who passed the under 18 tanning legislation. There are 42 states with some tanning regulations, but we don't have enough, and I really have to credit Sam and everyone for helping to do this, not only in California where we were the first state in 2011 to enact the ban, but really in all the other states, and they continue to do so. And we're not where we should be. I mean, Australia has banned tanning beds entirely, as has Brazil. So what about skin cancer prevention and sunscreens? We couldn't say before 2010 that sunscreens actually prevented melanoma until this study out of Queensland, Australia was published. And this was a very ambitious study enacted in the 1990s, a 4-year intervention of daily use of sunscreen, old sunscreen, SPF 16, not as good as what we have today, only to the head and arms of individuals on a daily use for 4.5 years versus a control group of 800 patients who used it discretionarily, meaning optionally. And 10 years then after the 4-year intervention, there was about a 50 to 75% reduction in melanoma risk. So this is the first time we had evidence that sunscreen can make a difference. Now, what we understand is this was restricted to patients between the ages of 25 and 75. So obviously, if we enact these sun protective behaviors and sunscreen use in younger age children with better sunscreens, more broad spectrum sunscreens, we're likely to make a difference. So broad spectrum sunscreen has to block both the shorter wave ultraviolet B and the longer wave ultraviolet A. And we know a lot about the harmful effects of ultraviolet A because of the tanning beds, because they emit, again, more UVA than UVB and certainly relate to melanoma. Ultraviolet A goes all the way to 400 nanometers. The best sunscreens in the United States only go to 370 nanometers. That's the wavelength of ultraviolet light. And the best chemical that we have in the U.S. to block UV filter, not to filter, I should say, UV light, nothing really blocks it, is avobenzone. Avobenzone was in and out of our FDA approvals, came back in the approvals around 2009, 2011. It's photolabile, meaning it breaks down in the sun, so that's not very helpful for a sunscreen to break down in the sun. It has to be stabilized with other filters. We use octocrylene. So all broad spectrum sunscreens that are actually effective in the U.S., and the chemicals are actually better than the minerals, they contain avobenzone and octocrylene. What's so frustrating to all of us in the cancer control realm, though, is that there are photostabile, far superior UV filters that go across the entire spectrum that have been developed and approved in Europe, Australia, Japan, Israel for the last 3 decades. And we've tried to get these into the U.S. market through what's called a time and extent application. So 180-day approval from 2002, where the FDA was supposed to decide on these sunscreens in 180 days using the worldwide data. Well, that didn't happen, and it's really prompted a lot of cancer control agencies advocating for these filters in our sunscreens to have President Obama sign the Sunscreen Innovation Act in 2014. This was mandating the FDA to make a decision on these 8 superior sunscreen molecules. So what happened 3.5 years ago in March 2015 is the FDA just rejected all of them soundly, told all the companies to reapply, give more safety and efficacy data on percutaneous absorption, safety in pregnant women, despite the fact that these are used worldwide. So it's very, very frustrating. Nothing's happened since then, and we don't anticipate in this political climate that sunscreen safety is going to be a priority. Now, what about melanoma mortality? Melanoma mortality, we'll see about 10,000 cases of melanoma this year, more in men than women, and I'll talk a little bit about why. The mortality rates for melanoma on the most current data are actually climbing a little bit less steadily. So they're climbing steadily, but they're climbing to a lower rate. So we used to see melanoma mortality in the United States rise at about 2% per year. We're now seeing it at 1.5% per year. And we anticipate these rates will continue to decline with the better treatments that will be talked about this morning. We have seen, though, continued rates of melanoma mortality in particularly older white men. And we know despite the better treatments we have for advanced melanoma, where we really make progress is if we detect the disease early before it really has a chance to metastasize. It's been said that melanoma writes its message in the skin with its own ink and for all of us to see. So why is early detection of a visible, largely visible skin cancer so difficult? This really requires some understanding of the biology of tumors. Some of them grow quickly. They elude early detection. They might not be pigmented, so they might not be recognizable to a patient or provider as melanoma. The epidemiology, who gets melanoma, who succumbs to melanoma, and then really the sociology. What are those behaviors in a population or a group of individuals at risk that help with early detection and or prevention strategies? We know that physicians find thinner, more curable melanomas than patients, and what that means is by the time a patient comes to us with a bleeding lesion on his or her back that they notice when they rub with a towel, that's generally a much more advanced T4 melanoma compared to that T1 or in situ melanoma that a physician can find incidentally or opportunistically during screening. We also know that individuals who have lower socioeconomic status, which I'll abbreviate SES, and middle-aged and older men tend to die more from melanoma. Now, SES and melanoma are tricky. Melanoma is a high SES cancer. We see the most number of cases in wealthier, high SES white individuals who are more susceptible because of their skin phenotype. But we see most deaths in lower SES individuals, and this is what we see all the time at Stanford. We are going to start a neoadjuvant program where we're going to be using therapies before surgery. We have the population for this, as I'm sure Adil and others at Kaiser do. Patients coming from the Central Valley with big, bulky tumors tend to be of lower SES. We have done some studies with the Cancer Prevention Institute of California, which has been aligned with Stanford and is now aligned with UCSF, but we've really shown that the steepest rises in the thickest tumor incidence raises, so the steepest rises in the worst tumors, those with ulceration, regional nodal disease, or just thick primary tumors of the skin, are really in low SES individuals. At Stanford, about a decade ago, we and our colleagues at Michigan looked at a lot of the behaviors and attributes of thin versus thick melanoma and what really led to that. And we in particular were interested in what the links are between the low SES and detection. And most of our patients who even in the Valley have very good access to primary care docs, less so to specialists like dermatologists and medical oncologists, but they tend to have primary care access. But what we found is that the lower educated patients were less likely to do skin exams to understand melanoma awareness and warning signs, and even if they had a changing lesion, they were less likely to talk to their doctor about it. In turn, this was bidirectional. The physician was less likely to teach them about melanoma warning signs, teach them how to do a skin self-exam, and about half as likely to perform a skin exam. So what we really need to do is increase physician awareness of these health disparities based on social class in communication and care, and that's going to help us reach these patients better. Middle-aged and older men, this is looking at Connecticut Tumor Registry data. The Connecticut Tumor Registry has been in existence since the 1950s. It's the oldest in the country, and it and any registry around the world have really shown this marked increase in melanoma incidence, including the thickest tumors in middle-aged and older men. About 60% of the melanoma deaths we see are in white men age 50 and older, and we believe this is probably related to both behaviors and biology. We've done some work on biology considering whether this is hormonally related, not so much to estrogens, but maybe to the androgens or to the immune responses and so on, though we see many fewer immune effects on the checkpoint inhibitors in on older white men, or the older men. Behaviorally, men are less likely to participate in healthcare screening and to navigate the healthcare system as well as women. And we, again, a while ago looked at reaching out to middle-aged and older men to really determine these factors, and again found that physician detection is the main way we want to enhance earlier detection. We want to raise the role of a partner or a spouse to look at the back in particular, because about a third of melanomas in men occur on the back. These tend to be thicker melanomas, perhaps more nodular subtype, which grow quickly. But again, we found that physician detection of these tumors, again, when it's incidental, when the physician's lifting up the shirt to listen to the lungs or looking at the heart and so on, we are going to pick up a thinner melanoma than when a patient or a spouse does. So we devised this campaign, Watch Your Back. If anybody wants the PDF of this, they're welcome to it. We gave it to Homeland Security at the time, and it went out to Border Patrol. But this is really emphasizing the need to look at the back in an older male, whether it's the patient advocating for the physician to do it or just the family member or spouse. So very important. If we could reduce thick back melanomas in men, we'd actually make a difference in mortality. We know that skin exam makes a difference. In the same study we did looking at social class, we looked at whether a patient was seen by their physician in the year prior to diagnosis, and whether that physician diagnosed the melanoma. Just having that exam in the year prior to diagnosis probably raises awareness, and we found the greatest benefit of physician skin exam, a full exam, being related to thinner melanomas in older men. The problem is that skin exams are actually uncommon for primary care doctors to perform, and primary care doctors are very pressed in their time. There's a lot of competing morbidities, and they actually receive advice on what kind of full exams they should be doing from the USPSTF, which is the Preventive Services Task Force. When this survey was done in 2010, it showed that only 20% of individuals are routinely getting a skin exam or had reported a skin exam by their primary care provider, compared to other screening exams for breast cancer, colorectal cancer, and prostate cancer. Now, the USPSTF is making these recommendations for our primary care colleagues in terms of screening, counseling, and preventive medicine, and they're really looking at the most value of time in the primary care practice setting for the yield. And if you're familiar with, now if you've been to your doctors more and more, you may be asked, do you want to put on a gown? Which shocked me when I turned 50 a few years ago. And I said, well, you're not going to examine me? And they said, well, do you have any issues you want me to look at? Well, you're a dermatologist. We don't need to look at your skin. So it is really different in terms of what in large health systems primary care docs are doing. It's more counseling. The USPSTF makes recommendations on screening, counseling, and preventive services, rating them from an A to recommend to a D to not recommend, and then the lovely I statement, which is kind of insufficient evidence. And that's where we stand with melanoma. We have an I statement for visual skin examination by primary care clinicians for skin cancer detection. And the reason is the USPSTF, they looked at data through 2015, felt that they couldn't balance the benefits of this versus the harm. They also felt that there wasn't enough data to show that skin cancer screening reduces morbidity, meaning complications from the disease, or mortality, deaths from the disease. They do continue to note the value of screening individuals at the highest risk who will die from melanoma, so older men, those with atypical moles who have high risk of getting melanoma. And importantly, the USPSTF since 2012 has recommended skin cancer prevention counseling by pediatricians, and luckily they just reduced the age to 6 months. So they were saying do this between 10 to age 24. This is a category B, and in the Affordable Care Act that allows the primary provider to actually get some reimbursement for the counseling. But right now they reduced it to age 6 months, which we're happy about. What are the harms of screening? Psychological harms related to anxiety. We see a lot of patients, or I do, who are unfortunately have had molectomies, all of their moles removed to prevent melanoma, which makes no sense. And then we worry about the screening in terms of overdiagnosis, unnecessary biopsies. So physical effects and psychological effects are the potential harms. And I want to mention screening in Germany. This is really where we've had the country of Germany and the state of Schleswig-Holstein, the northernmost state, have really remarkably advanced our understanding of what physician screening, primary care screening can do. And the northernmost state of Schleswig-Holstein, here should light up, has Denmark to the north, and in 2003 to 2004, they enacted a public campaign beforehand that had trained their primary care docs in the state, and it was huge buy-in on 8-hour course to how to do skin cancer screens. They screened over 360,000 patients, and they actually found that 5 years after the screen, a nearly 50% reduction in melanoma deaths in Schleswig-Holstein compared to surrounding states, Denmark, and historical data. So this was incredible. We're like, wow, screening by primary care docs makes a difference. Germany, the entire country, enacted nationwide screening starting in 2008 based on the pilot data here, and they raised the age to 35 rather than 20. They trained over 45,000 MDs in the same 8-hour course, and they actually then were really hoping. They didn't have the same pre-screening publications or advertising to patients, but they were really hoping, or everyone in the melanoma community was hoping we'd see a difference. And unfortunately, we did not. So the first 5 years of data have been analyzed with nationwide screening and have shown no reduction in mortality rates in Germany as a whole or in Schleswig-Holstein 5 years after nationwide screening started. And there's a lot of reasons for this, but it's disappointing. We do have some newer data, though, out of the University of Pittsburgh, which enacted a sort of dual program to the Schleswig-Holstein, engaging their senior leadership at UPMC, which covers 18 counties in western Pennsylvania. It's an enormous enterprise. And they screened over 51,000 patients by PCPs in January 2014 to January 2015. They used a much shorter program called Informed, which is web-based, and they found no impact on skin surgeries or derm visits, which is good. That's kind of a lack of harms. And then they've actually found in the screen patients that they tend to be diagnosed with thinner melanomas, more melanomas in situ, and were more likely in general to be diagnosed with melanoma because the PCP is looking. So this is some very hopeful data, again, not incorporated into the last USPSTF statement. I just want to mention, though, we did a pilot study at our VA Palo Alto, which is a high-risk, high-yield population, so predominantly older white men with a ton of sun exposure and a ton of melanomas, and deep melanomas, too. And we have actually found that in a pilot program with 6 of our PCPs who volunteered to do the Informed and screened over almost 200 patients over a period of time, and pre and post time, we also found no harms in terms of the derm referrals, skin surgeries, and so on. But patients really liked this. They thought it enhanced the quality of the visit. They felt that it was a value added to their health care, but the physicians are really time limited. So it's going to limit what we can do when the patients are older and have many other health problems, more pressing problems in terms of their cholesterol and hypertension and heart disease and and drug addiction and all these other different things that are going to really come into account whether we can ask our primary care colleagues to do the screening and get them to the right specialists. So what do we need to do in the absence of the screening? We need to involve state-based projects like War on Melanoma, and I'm going to talk about this because this really combines media, community outreach, and public education. This was started by Sancy Leachman at OHSU, Oregon Health Science and University in 2014. It's a community registry, but what War on Melanoma is doing is to look at how we can reach patients, family, and friends, so survivors and families and high-risk individuals through education and then activism, legislation. They've enacted legislation to mandate shade structures in schools and so on. And then research, Mole Mapper is a phone app that's actually looking at, let me just get to the next slide, how we can detect lesions. And so there are different things we can do. We are becoming involved in the War on Melanoma, and I'm running this new War on Melanoma California effort, which will now, we hope, really reach out to those lower SES folks, the most fatal melanomas in the state, through community outreach. I have a number of colleagues around the country who are doing the same, and we all have sort of different targeted groups that we're going to start with, but we're very excited, and we'll obviously partner with AIM on melanoma as this moves forward. We're actually partnering with Cedars-Sinai right now to do focus groups in the Hispanic population as well, because we're seeing higher rates of melanoma develop there. I'll skip this next slide, but I'm happy to talk about our War on Melanoma efforts down the line in California, and this is a conjunction with OHSU for a sort of a nationwide effort to engage the community in a way that really helps us move the ball forward in terms of prevention strategies. We at Stanford, and there's been some work at UCSF and other centers, have also looked at machine learning through artificial intelligence, and we published sort of a landmark paper in Nature a year and a half ago looking at how deep learning algorithms, namely a single convolutional neural network, could help us detect melanoma, and particularly if we could put this in the hands of patients down the line in an app or primary care providers. But we did a concept or a proof of concept study looking at the CNN algorithm compared to dermatologists in academic centers. Most were not pigmented lesion experts. I am in this one, and I think I'm the dot above it, which is good because I want to perform better than the machine. But what this proof of concept showed is that we really can train AI to do as well or nearly as well as dermatologists in many aspects of looking at lesions, and there's a lot of work to do. This is just a preliminary study. I'll just end on a few slides on therapeutic prevention. We tend to use that terminology over chemoprevention because chemoprevention implies we're using chemotherapy. So therapeutic prevention is really trying to reduce or lower the risk or prevent melanoma at the outset in individuals at high risk and in other individuals using safe and effective available drugs like aspirin or nonsteroidal anti-inflammatory agents, vitamins, supplements, and so on. Could we even give somebody a drug that increases their tanning without UV exposure? And that's being looked at by colleagues in Harvard, so it's very appealing. We haven't yet found the right agent. We are looking very diligently, and we have a new paper that's coming out in Cancer that really reviews the current state of chemoprevention. But what we'd like to do through the Melanoma Prevention Working Group, which I co-direct with John Kirkwood out of Pittsburgh, and then Sancy Leachman, who's at Oregon, co-directs on the SWOG side, which is an intergroup effort with Tony Rebus down at UCLA, is we really want to focus on a phase 3 chemoprevention trial in high-risk individuals in the U.S. through the intergroup, or NCTN, the National Cancer Trials Network. And so we're really working diligently to this so that we could see a graph like this down the line where we enact a chemoprevention strategy that takes the incidence of melanoma down, 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 and in turn brings mortality to almost zero if we can prevent the disease. So I think, just on time and happy to answer questions, and I will also be glad to, it always comes up in these forums, which sunscreens I recommend, and the ones that I tell my patients to get from Canada and other countries. Legal to do so, but they have the better filters. And I thank you for your time.